Can you hear me now? Can you hear me now? Okay. What was the last thing you heard? What was the last thing you heard? Quickly, quickly. What was the last thing you heard? Somebody answer.
The last thing you heard was the diagram with the meninges, right before you went off for the couple seconds break.
Okay. All right. So let me go back here. All right. So what I was saying is the correct pronunciation for the meninges is the dura mater, arachnoid, and pia mater. I was butchering the pronunciation. I was also saying that you need to be familiar with the layout of the meninges. So how it is laid out on this diagram, always picture it that way. Dura, arachnoid, pia. It's important for you to understand that layout because bleeding can occur above or under the tough layer. It can occur within the arachnoid layer, or it can occur within the brain tissue. Cerebrospinal fluid. Cerebrospinal fluid is produced in a chamber inside the brain called the third ventricle. Approximately 125 to 150 mils of CSF is in the brain at any time, and it's not really in the brain, it's inside the cranium or skull. And it acts as it is a shock absorber for the brain, so it protects the brain, it cushions the brain. Within the peripheral nervous system, we have the somatic nervous system, which has 31 pairs of spinal nerves that conduct impulses from the skin and other organs to the spinal cord. They conduct motor impulses from the spinal cord to the muscles, and the spinal nerves serving the extremities are arranged in a complex network or complex networks. Within the peripheral nervous system, we have the autonomic nervous system, and within the autonomic nervous system, we will find 12 pairs of cranial nerves. They transmit information directly to or from the brain and perform specific functions in the head and face, including sight, smell, taste, hearing, and facial expressions. Two types of nerves you need to be familiar with within the peripheral nervous system is your sensory nerves, which carry only one type of information from the body to the brain via the spinal cord. Motor nerves, there is one for each muscle. They carry information from the CNS to the muscles. Be familiar with these nerves. Come on, move forward. Then you have your connecting nerves. Now, the connecting nerves connect sensory and motor nerves. Found only in the brain and spinal cord, connect the sensory and motor nerves with short fibers. It allows the exchange of simple messages. And this is the route that impulses will take when bypassing the brain. So if it's a reflex action, it moves from the sensory nerve to the connective nerve to the motor nerves. It doesn't go up to the brain. How the nervous system works. It controls virtually all the body's activities, including reflex actions, voluntary activities, and involuntary activities. Connecting nerves in the spinal cord form a reflex arc. If a sensory nerve in this arc detects an irritating stimulus, it bypasses the brain and sends the message directly to a motor nerve. I've already explained that. Voluntary activities we consciously perform. Involuntary activities are the actions that are not under conscious control. Somatic or voluntary nervous system handles voluntary activities. The autonomic involuntary nervous system handles body functions. It divides into two sections, the sympathetic and the parasympathetic nervous system. The sympathetic nervous system reacts to stress with a fight or flight response, and the parasympathetic nervous system has the opposite effect on the body. Now, the skeletal system review. Skull composed of two groups of bones, cranium, thick shell above the eyes and ears that protects the brain, and the facial bones. Still on the skull, the cranium is composed of 80% brain tissue, 10% blood supply, and 10% cerebrospinal fluid. Four major bones make up the cranium, and these bones take the name of the lobes of the brain: occiput, temples, parietal region, and frontal region. The face is composed of 14 bones: the maxillae, zygomas, mandible, and orbit. The spinal column is the body's central supporting structure. 33 vertebrae are divided into 5 sections. So you have your cervical, thoracic, lumbar, sacral, and coccygeal. We have 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacrum, 4 coccyx fused. Spinal column. Injury to the vertebrae can result in paralysis. And I mentioned the different types of paralysis that can occur yesterday. Vertebrae are connected by ligaments and separated by cushions called intervertebral discs. The spinal column is almost entirely surrounded by muscles. All right, now let's look at the injuries. Head injuries. Traumatic insult to the head that may result in injury to soft tissue, bony structures, or the brain. 52,000 deaths occur annually in the United States as a result of severe head injury. And I would imagine that the statistics are probably similar or higher in Jamaica. It accounts for more than half of all traumatic deaths. Now, the worst trauma patient that you can get is a patient with suspected head and spinal injury, and that patient is having ventilation issues. That's the most difficult emergency you can get for a trauma patient. Closed injuries. With closed injuries, the brain has been injured, but there is no opening into the brain. With open injuries, an opening from the brain to the outside world exists, often caused by penetrating trauma, maybe bleeding, and exposed brain tissue. Motor vehicle crashes are the most common MOI. So MVAs are the most common MOIs for head injury. Head injuries are also head injuries also commonly occur in victims of assault, It is common in the geriatric population because over time their balance is not good, so they are prone to falls and they will fall and hit their head. It is common during sports, especially contact sports, boxing, American football, MMA, mixed martial arts, in a variety of incidents involving children. Any head injury is potentially serious. Now, scalp lacerations, they can be minor or serious. Even small lacerations can lead to significant blood loss. May be severe enough to cause hypovolemic shock. They are often an indicator of deeper, more serious injuries. So it can be a tiny cut and they are bleeding excessively because of how vascular the scalp is. Skull fracture. Significant force applied to the head may cause a skull fracture. It may be open or closed. It may be open or closed depending on whether there's an overlying laceration of the scalp. Injuries from bullets or other penetrating weapons often result in skull fractures. Signs of skull fracture include the patient head appears deformed. There is visible cracks in the skull. The patient can present with discoloration or ecchymosis that develops under the eyes or behind the ears, and these are late findings. So these are not things that you will see early in a patient with a skull fracture. So it doesn't mean that if they are absent, the patient doesn't have a fractured skull. Linear skull fractures accounts for about 80% of all skull fractures. So majority of the skull fractures are going to be linear. Linear, the term linear means it's in a line. Radiographs are required to diagnose a linear skull fracture because there are no physical signs. Depressed skull fractures. Now, a depressed skull fracture results from significant force applied to the head, usually blunt force trauma. Frontal and parietal bones are most susceptible. The bone fragments are driven into the brain tissue. Then you have your basilar skull fractures. Again, this is another one that is associated with significant force applied to the skull. Usually occur from diffuse impact to the head. Signs include CSF drainage from the ears. Patient will present with raccoon eyes and battle signs in later stages. Open skull fracture result when severe forces are applied to the head, often associated with trauma to multiple body systems. The brain tissue may be exposed to the environment. Let's look a little more closely at traumatic brain injury or injuries. Most serious of all head injuries. So this is the worst injury the patient can get, a traumatic brain injury. Two broad categories exist. You have primary direct injury, which is direct injury to the brain tissue itself. And then you have secondary, which is things that result from the direct injury. So primary brain injury results instantaneously from impact to the head. Secondary brain injuries or injury increases the severity of the primary injury. So secondary injury are things that will develop as a result of the primary injury. And these are things like hypoxia, hypotension, cerebral edema, which is swelling, intracranial hemorrhage, increased intracranial pressure, which is something that is very bad for a patient with a head injury. So once their ICP starts to go up, they're in trouble. Cerebral ischemia, the term ischemia means lack of oxygen, and infection. The brain can be injured directly by penetrating object or indirectly as a result of external forces. Coup, contra coup, that's how that word is pronounced, it's French, is basically an injury in which the anterior and posterior areas of the brain is injured. So a coup contra coup injury can result from striking a windshield. The head hits the windshield, the brain comes to an abrupt stop by striking the inside of the skull, and then the head falls back against the headrest. The brain slams into the rear of the skull. Intracranial pressure. The accumulation of blood within the skull or swelling of the brain can rapidly lead to an increase in intracranial pressure. So ICP pressure needs to be at an acceptable level in order for the brain tissue to be properly perfused. So ICP is important to cerebral perfusion pressure. So if it starts to get too high, it can cause complications. Now, and it can be because blood is accumulating inside of the skull and creating pressure on the brain, or it can be because the brain tissue itself is swelling, and it can be a combination of both bleeding and swelling. It can become so severe that it starts to push the brain out of its normal anatomic position, and the brain starts to herniate. The issue with raised intracranial pressure is how the body compensates for raised intracranial pressure actually makes the condition worse. So when the intracranial pressure starts to rise in the skull, the body is going to try and compensate for that by increasing the blood pressure, because the body feels like the brain is not getting enough blood flow. But the reason why the brain is not getting enough blood flow is because there is something creating compression on the blood vessel. But the body doesn't understand that. It believes that the brain is not getting adequate blood flow. So what the body is going to try to do is increase the blood pressure. So the patient's blood pressure is going to start to go up. And then the body is going to open up the blood vessels that supply the brain. So it's going to cause cerebral vasodilation to get more blood going to the area. Now, if there is swelling and bleeding already occurring there, and the body increases the blood pressure, it's going to make it worse, right? So how the body compensates for it makes it worse. Increased ICP squeezes the brain against bony prominence within the cranium, and it can get to the point where the brain tissue starts to herniate, or the brain itself starts to herniate. Signs of intracranial pressure rising: chain strokes or Cheney-Stokes respiration. Went through that before. Ataxic biot respirations. Decreased pulse rate, so the pulse rate starts to go down. Headache, nausea, vomiting, decreased alertness. You will see bradycardia, sluggish or non-reactive pupils, and you will see decerebrate posturing, where the hands start to come in towards the chest and stiffen up, so that the hands are flexed and stiff against the chest, the center of the chest, and the toes stiffen up and point out. And you will see Cushing reflex or Cushing triad. And what Cushing triad is, the blood pressure goes up, pulse rate slows down, breathing slows down or becomes irregular. Now, intracranial hemorrhage. Bleeding inside the skull also increases ICP. Bleeding can occur between the skull and the dura mater. That would be classified as epidural bleeding. It can occur beneath the dura mater but outside the brain. That would be subdural, right? So that's a subdural hematoma. It can occur within the tissue of the brain itself, so they can have intracerebral bleeding. So let's look at an epidural hematoma. So this is a patient who has been hit in the head. And when they get hit in the head, they lose consciousness, and that blow damages the middle meningeal artery. So epidural hematoma is going to be an arterial bleed. So the person gets hits in the head, they lose consciousness, right? And then they regain consciousness. So they are knocked out, lose consciousness, regain consciousness, and then they gradually decline. So then you start to see a gradual decline in their level of responsiveness until they are no longer responsive. That's an epidural hematoma. So it's accumulation of blood between the skull and the dura mater, nearly always the result of a blow to the head that produces a linear fracture. Now the subdural hematoma, the subdural is below, right? Arteries lie closer to the surface of the skin, veins are deeper. So a subdural hematoma is going to be a venous bleed. Now, this is common in your geriatric population. As we get older, the brain tissue starts to atrophy or shrink in its size, and that creates more space inside the skull. When this person falls, if they hit their head, sometimes it will cause a blood vessel to tear. It's not an arterial blood vessel, so the bleeding doesn't occur rapidly. It slowly occurs. So what you will hear for the history, or what you are told by caregivers, is that she fell probably a couple days ago, 5 days ago, and we noticed that she's not behaving normal anymore. So over a period of days, the patient's level of consciousness is going to change as the bleeding starts to accumulate. That's a subdural hematoma. So it's the accumulation of blood beneath the dura mater, but outside the brain. It occurs after falls or injuries involving strong deceleration forces. It may or may not be a skull fracture. So they can have a skull fracture and it can be absent. Now, intracerebral hematoma. This is bleeding directly inside of the brain tissue. This is a tough one for this patient. So bleeding within the brain tissue itself can occur following a penetrating injury to the head or because of rapid deceleration forces. Then we have the subarachnoid hemorrhage, and this is below the middle layer, which is the arachnoid layer. Bleeding occurs into the subarachnoid space where the CSF circulates. Now, because just below the arachnoid is the soft layer, the pia mater, which is directly attached to the brain tissue, when this bleeding occurs, it can start to create irritation on that layer, and the patient start to complain of a severe headache. They will also sometimes start to vomit. So results in bloody CSF and signs of meningeal irritation. Common cause include trauma or rupture of an aneurysm. Now, concussion. A concussion is a blow to the head or face, and it concusses the brain. So it jars the brain around. There is no physical damage identified to the brain at that point, but the person loses consciousness, and they can regain consciousness as well. But when they regain consciousness, their memory is not good. So they either have issues with memory before or after the incident. So a concussion is a close injury with a temporary loss or alteration of part or all of the brain's ability to function without demonstrable physical damage to the brain. So they cannot detect any physical injury to the brain. About 90% of patients do not experience a loss of consciousness, right? So they may or may not. A patient with a concussion may be confused or have amnesia. So they're going to be disoriented and they may not be able to tell you what happened before. Right? So they may not be able to tell you what happened before or after the injury occurred. Usually a concussion lasts only a short time. However, there are studies now being done on concussive syndrome or concussion syndrome, which is more of a long-term issue. They're also starting to look more closely at CTE, which is chronic traumatic encephalopathy. And that is caused from repeated trauma to the head, repeated concussions over years. So it is a fatal brain disease and it cannot be diagnosed until the person is dead. They're picking it up a lot in persons in combat sports and full contact sports. So what happens to the persons with CTE is over time, their cognitive abilities decline. They can even have extreme changes in their emotions. So if they were usually calm, they get very aggressive, they get very erratic in their actions. Their speech start to be affected. They can develop dementia, so that's CTE. And concussive syndrome is associated with CTE, but this concussion that we're talking about is temporary. Right? So ask about these symptoms: dizziness, weakness, visual changes, nausea and vomiting, ringing in the ears, slurred speech, inability to focus, lack of coordination, delay of motor function, inappropriate emotional responses, temporary headache, disorientation. Now let's look at a contusion. A contusion is much more serious than a concussion because it involves physical injury to the brain tissue. may sustain long-lasting and even permanent brain damage. A patient may exhibit any or all of the signs of a brain injury. Now, other brain injuries. Brain injuries can also arise from medical conditions such as blood clots or hemorrhages. And we're talking about stroke at this point, right? So it can be a stroke caused by a clot, or it can be a stroke caused from hemorrhaging. Signs and symptoms of non-traumatic injuries are often the same as those of traumatic brain injuries. There is no obvious history of MOI or any external evidence of trauma. Spine injuries. Compression injuries can result from a fall. Forces that compress the patient's vertebral body can cause herniation of disc. Motor vehicle crashes can overextend the spine. So if the spine is overextended, whether it's to the side, left or right, flexed or back, an extension would be when it goes back, flexion would be when it goes forward, right? So when you bend your head forward, that's flexing. When you bend the head back, that's extension. So injuries can occur from motor vehicle crashes that can overextend the spine. They can have rotation and flexion injuries of the spine, which result from rapid acceleration forces. When the spine is pulled along its length, hyperextension, it can cause fractures. Any one of these unnatural motions, as well as excessive lateral bending, can result in fractures or neurologic deficit. When bones of the spine are altered from traumatic forces, they can fracture or move out of their normal position. Now, patient assessment. Always suspect a possible head or spinal injury with MVAs, pedestrian versus motor vehicle. Motor vehicle always win. Falls, blunt trauma, penetrating trauma to the head, neck, back, or torso. Very important statement. Penetrating trauma to the head, neck, back, or torso. So if you have a patient with penetrating trauma to the torso, we should be thinking about possible head spinal injury or spinal complications. Always suspect a possible head or spinal injury with rapid deceleration injuries, hangings, axial loading injuries, and diving accidents. Perform your scene size up. Ensure your scene safety. Evaluate every scene for hazards to your health and the health of your team or bystanders. Be prepared with appropriate standard precautions, including gloves, a mask, eye protection. Call for ALS as soon as possible. Scene size up. Continued. Mechanism of injury or nature of illness. Look for indicators of the MOI. Consider how the MOI produced the injuries expected. After we have completed our scene size up, so we need to ensure the scene is safe, take standard precautions for ourselves or crew, identify the mechanism of injury. Is it localized? Is it significant? Do I have one patient or multiple patients? Do I need additional resources? After your scene size up, the next phase is your primary assessment. And the first thing we need to do is form a general impression as we approach the patient. So focus on identifying and managing life-threatening concerns, threats to circulation, airway, or breathing, or external hemorrhage. Reduction of unseen time and recognition of critical patient increases the patient's chances for survival or a reduction in the amount of irreversible damage. So our goal is to stabilize within 10 minutes or less than 10 minutes. Spinal immobilization consideration. Assess the patient in the position found. And when you're approaching a patient that you suspect has spinal injury, you always approach in the line of sight. So you approach in the line of sight and you simultaneously control the head and talk to the patient. So you approach them in the line of sight, simultaneously grab hold of the head and neck. Sir, ma'am, if you can hear me, don't move your head. So while I'm controlling their head and neck, I'm talking to them. Assess the patient in the position found, determine whether or not a cervical collar needs to be applied, assess the scene to determine the risk of injury, form a general impression based on the level of consciousness, and chief complaint. The backboard often places the patient in an anatomically incorrect position for a long period of time. So you need to be aware of that. Patient is going to be in a position that they're not comfortable in. So the new guidelines do not keep patients on spine board for a very long time. With the new guidelines, we actually just use the board to move them from the field to the back of the unit. Once the patient is in the unit on the stretcher, we pull the backboard apart or we take the patient off the backboard. And that is why the scoop backboard is being used more now than the regular spine board. So the backboard often places the patient in an anatomically incorrect position for a long period of time. Circulation to areas of the skin may become compromised. So patients that are on a backboard for too long, the circulation to the skin can be compromised, and you'll see that a lot in the geriatric population. Their data has been produced to show that as little as 30 minutes for a geriatric patient on a spine board can cause the tissue to start breaking down. The other thing is that the patient is in a flat position. When we're in a flat position, the alveoli collapse. When our alveoli collapse, we sigh or we turn. Right? So if you're lying on your back in your bed and your alveoli collapse, once you turn, it opens up. A patient that is on a spine board cannot turn. So if their alveoli collapse, it's going to stay collapsed. And that can cause issues for the patient because once the alveoli flattens out, diffusion doesn't occur very well and more surface area is available for bacteria to act on. So the spine board can actually interfere with airway management if the patient is on it too long. Try to minimize the amount of time a patient spend on a backboard. And that is what the new guidelines are pushing. Limited time on the spine board. The cervical collar helps maintain spinal motion restriction. So the cervical collar goes around the neck. Note the term that is used here. So the cervical collar cannot immobilize the spine in the neck. Cannot. All it does is restrict the movement of the neck. The best time to apply the cervical collar depends on the patient's injuries. Now, what I always tell my EMTs is once you have completed your ABCs and you have started your rapid scan and you get to the neck, put the C collar on the patient at that time, right? So let me repeat that. Once you have completed your ABCs and address live threats, and you are going to do a rapid scan on this patient, you check the head. When you get down to the neck, secure the neck with a C collar at that point. If you put on the C collar early and your ABCs are not done, I may have to take that off. So when I come as a paramedic, if you didn't do a proper ABCs before putting on the C collar, I will have to take that collar off. It's going to interfere with my assessment, and it can affect your ability to manage the patient's airway if you put it on too early. So don't be in a hurry to put on a C collar. Very important point. So it helps to maintain spinal motion restriction. The best time to apply the cervical collar depends on the patient's injuries. Once the cervical collar is on, do not remove it unless it causes a problem with maintaining the airway. Now, my problem with the EMTs currently is the skill is not being done properly. So what I've seen in the videos, what I've observed with patients coming into the hospital, the skill is not being done properly, and that is right across the board. So we're not measuring the C collar properly and putting it on the patient neck. Very often I see patients coming in and the C collar is over the patient chin. We're not securing the patient properly on the board either. It's like we're rushing to get them on the board and then pick them up. If you have a patient on a spine board that is properly secured, you should be able to turn the board on its side and the patient don't move. If you cannot turn that spine board with the patient on it without them shifting, the patient is not properly secured on the board, right? So rushing to do something makes no sense if when you're rushing, it is not done properly. So if you rush to do something and the end result is it's not done properly, then you shouldn't be rushing to do it. Right? I've had worked with quite a few people that I have to take the C collar off that the EMT put on and resize it because it wasn't put on properly on the patient. I've worked with persons that I end up have to be putting padding in spaces between the patient and the board to ensure that the patient is not shifting all over the place. So again, if you're going to rush to do it and it's not done properly, it's not benefiting the patient. Assess for signs and symptoms of head and spine injury. Ask about the chief complaint. And with your trauma patients, that you suspect a significant MOI, it is important. It is important to find out if they lost consciousness. It is important to determine their level of orientation. Are they oriented to person, place, time, and event? Confused or slurred speech, repetitive questioning, or amnesia in a responsive patient is a good indication of a head injury. In the setting of trauma, assume your patient has a head injury until your assessment proves otherwise. If the patient is found unresponsive, emergency responders, family members, or bystanders may have helpful information. Unresponsive trauma patients should be assumed to have a spinal injury. Patients with decreased level of responsiveness should be considered to have spinal injury based on their chief complaint. In your primary, as usual, we have to focus on airway breathing and circulation considerations. Use a jaw thrust maneuver to open the airway. If the jaw thrust maneuver is ineffective, then you go back to your head tilt, chin lift, control method, right? So controlled head tilt, chin lift, which is all you're doing is a slow head tilt, chin lift until you have enough room to put a airway adjunct if it is required. Vomiting may occur in the patient with a head injury. So vomiting is very common in head injury patients. Irregular breathing may result from increased ICP. Oxygen is always indicated for patients with head and spine injuries. So it's very important that your patient with a head injury, head or spinal injury, that their pulse ox stays in the 90s. So you don't want this patient pulse ox to drop below 90. That's going to affect the entire brain, not just the area of ICP, right? So if the pulse ox, if they start to get poorly oxygenated, it's going to affect cerebral perfusion. The entire brain will be affected. Now, there are some protocols that will allow responders to do hyperventilation for the patient. And what hyperventilation is, you would go at a faster rate for your adult. So if you normally breathe for the patient at 1 breath every 5 to 6 seconds for an adult, you would breathe for that patient at 1 breath every 3 to 5 seconds. So you're going to be breathing a bit faster. What that does is it introduces more oxygen into the body, which will cause the blood vessels to vasoconstrict. So it's going to cause the blood vessels to vasoconstrict and reduce the amount of pressure that is going to the brain. But as I said, you cannot perform this unless you have the protocols that allow it. And it is only done if the patient is showing signs of elevated intracranial pressure and is at risk for herniation. Outside of that, we don't do hyperventilation. Outside of that, the patient would require advanced intervention. So we have to take over the patient's airway using advanced method, intubation. A pulse that is too slow in the setting of a head injury can indicate a serious condition. So a slow pulse in a patient that you suspect head injury is bad. A single episode of hypoperfusion in a patient with head injury can lead to significant brain damage. I've already emphasized this. If they are not getting proper perfusion to their brain, the entire brain will be affected, not just the area where the pressure is high. So we can't allow them to develop hypoperfusion, or we have to recognize it early, and we cannot allow them to desaturate. Assess for signs and symptoms of shock, control bleeding. Manner of transport. Patients with impaired airways, open head wounds, or abnormal vital signs may need to be rapidly extracted from a motor vehicle and transported. Providing the patient with a patent airway and supplemental oxygen is paramount. Suction should be readily available, and we will maintain inline immobilization of the spine using equipment in the early stage manually, in the later stage equipment. After the primary assessment, and once we complete our primary assessment of the ABCs, we should know what the patient's GCS is, should know if the patient requires a rapid scan or focus. We should know if it's a load and go or stay and play patient. Once you get to the back of your unit, your patient is talking to you, it's time to get some information. Patient not talking to you, consider your physical findings, vital signs, and then who you can get information from. So history taking, investigate the chief complaint, obtain a medical history, and be alert for injury-specific signs and symptoms, as well as pertinent negatives. Using OPQRST may provide some background on isolated extremity injuries. Gather as much sample history as you can while preparing for transport. Once you have completed the history phase, next is your secondary assessment. Instruct the patient to keep still and not to move the head or neck. And if a patient is responsive and able to follow your commands, they will be able to do that very well. If the patient is hypoxic and combative or disoriented, they will not be able to do that task very well. So any patient that is conscious and they know that something is wrong with their neck, meaning there's pain or discomfort, they are not going to move their neck in a position to aggravate that once they are fully oriented. But the patient that is hypoxic, he's going to be the one that is trying to get up off the ground. He's the one that is going to try to turn the head this side. These are the patients that can be challenging. Physical examination, maybe a systematic head to toe, full body scan, or systematic assessment that focuses on a certain area or region of the body. Let me backtrack just a bit. Okay, good. Vital signs, significant head injuries may cause the pulse to be slow and the BP to rise. If you see a slow pulse and a rise in the BP and the breathing is starting to slow down, your patient is at risk for raised intracranial pressure. With neurogenic shock, the blood pressure may drop. So if they're in neurogenic shock, you're not going to see a high blood pressure. And the heart rate may increase to compensate. So this particular slide, pay close attention to it. So you need to know what you're looking for if the patient has raised intracranial pressure in comparison to if it's neurogenic shock. So if it's raised ICP as a result of the head injury, breathing will slow down or it becomes very irregular. The pulse slows down, the blood pressure goes up. If the patient is in neurogenic shock, the blood pressure drops, the pulse rate goes up. Pay attention to this slide. Respirations will become erratic and you're going to commonly see slow respirations. You can see irregular, but slow breathing is common. Use a monitoring device. Perform your full body scan using a decap BTLS IC. Examine the head, chest, abdomen, extremities, and back. Check perfusion, motor, function, and sensation. So if you suspect a spinal injury, you have to check pulse, motor, and sensory function. So if you suspect head or spinal injury, pulse, motor, and sensory function should be checked in all 4 extremities. The videos that I showed with the JDF, I'm not sure if that was done. I didn't see it on the video. I don't know what happened prior to the video, but I didn't see any checks being done to the extremities for the PMS. Now, if the patient is not responsive, you cannot do pulse, motor, and sensory. You can only check the pulses in the 4 limbs. You will also do PMS if you suspect injury, musculoskeletal injury to an extremity. So if it's an isolated injury to an extremity, PMS is required. A decreased level of consciousness is the most reliable sign of a head injury. Look for leaking blood or CSF. Assess the pupil size and reaction to light and continue to monitor the pupils. Do not probe open scalp lacerations with your gloved finger. Perform baseline assessment using your Glasgow Coma Scale. Always use simple, easily understood terms when reporting the level of consciousness. Record the levels of consciousness that fluctuate or deteriorate. Learn your GCS table. So learn this chart. Let me repeat it. Learn this chart. Once you start to do your long case trauma practice, I will expect you to tell me what the patient's GCS is. Make sure you learn this chart. All right. Spine examination, inspect for decap BTLS IC. This is the posterior portion. Check the extremities for circulation, motor, and sensory. If there is impairment, note the level. Pain or tenderness when you palpate the spinal area is a warning sign. Other signs and symptoms include deformity, numbness, weakness, or tingling in the extremities and soft tissue injuries. After your secondary, next phase is reassessment. Repeat your primary assessment, reassess vital signs and chief complaint, recheck the patient intervention. These injuries can suddenly affect the respiratory, circulatory, and nervous system. Reassess at least every 5 minutes. Intervention. Multiple interventions may be necessary in patients with head and spinal injuries. Compare baseline vital signs with repeated vital signs. Changes will often tell you if treatments have been effective. You will notice deterioration in a conscious patient's awareness of time, place, and person in that order. As I said, checking the orientation for these patients is extremely important. You must act quickly to evaluate and treat these patients. If CSF is present, cover the wound with sterile gauze, but do not bandage tightly. Administer high flow oxygen and apply a cervical collar. Communication and documentation. Your documentation should include the history you obtained at the scene, your findings during your assessment, treatments you provided, how the patient responded to them. Document vital signs for unstable patients every 5 minutes, for stable patients every 15. Now let's look specifically at the emergency medical care of head injuries. So 3 general principles. Establish an adequate airway, control bleeding, and provide adequate circulation to maintain cerebral perfusion. Begin CPR if necessary. Follow standard precautions. Assess the patient's baseline level of consciousness, and you need to continually monitor that. Managing the airway, the most important steps in establishing an adequate airway. We will be using a jaw thrust maneuver. Once the airway is open, maintain the head and cervical spine in neutral inline position until you have placed a cervical collar and have secured the patient on a backboard. Right? And that is what it looks like. Right? And the C color is going to be applied after you've done your ABCs and appropriate management, and you're doing your rapid scan. You get down to the neck, check the neck, then secure the neck. Ensure that your C color is properly sized before you place the device on the patient's neck. Managing the airway, remove any foreign bodies, secretions, or vomitus. Make sure a suctioning unit is available. Check ventilation. Give supplemental oxygen to any patient with suspected head injury. We do not want their pulse ox to go below 90%. That will cause the entire brain to be affected. Circulation, begin CPR if the patient is in cardiac arrest. In Jamaica, that's going to be very tough for you because we don't have coordinated responses in Jamaica. So it might just be you and your partner. and you and your partner cannot effectively manage a patient with head and spinal injury. It just can't work. You and your partner cannot effectively do CPR in the field. You're going to need assistance. So the more assistance you have, the more effective your management is going to be. And with a patient with head and spine, you need at least 4 persons, sometimes more. If you're doing a code in the field, you need at least 2 more persons or 1 more person. So I would say a minimum of 3 persons to be effective, but we don't have coordinated responses in Jamaica. So if a private company responds to a location, they are not going to call the fire brigade for assistance. If the fire brigade respond to a call, they are not going to call a private service or the JDF for assistance, which is mind-boggling to me because that's not how EMS works. Sometimes coordinated responses are necessary. But anyway, I digress. Don't want to stray off topic. You can almost, where was I? So begin CPR if the patient is in cardiac arrest. Active blood loss aggravates hypoxia. We don't want that to happen to these patients. You can almost always control bleeding from a scalp laceration by applying direct pressure over the wound. Shock is usually the result of hypovolemia, indicates that the situation is critical, transport immediately to a trauma center. They can have neurogenic shock as well, so look out for that. Cushing's triad, look for a Cushing's triad. If it's present, it means that your patient has raised intracranial pressure. So Cushing's triad, increased blood pressure, hypertension, the pulse rate slows down, and the breathing becomes irregular. So it's increased blood pressure, which is hypertension, decreased heart rate, which is bradycardia, meaning it's below 60 beats per minute, irregular respirations, which can be chain strokes, ataxic biotes, breathing or slow breathing, perform controlled hyperventilation. So once we suspect ICP, there are protocols that ICP rising, there are protocols that will allow us to provide hyperventilation for these patients to reduce the ICP. Follow standard precautions for your spinal injuries. Maintain the patient's airway while keeping the spine in proper position. Assess respirations and give supplemental oxygen. Managing the airway, jaw thrust maneuver. After you open the airway, consider inserting an oropharyngeal airway if all the indicators are present. Have suctioning unit available, provide supplemental oxygen. Immobilization of the cervical spine. Immobilize the head and trunk so that the bone fragments do not cause further damage. Never force the head into a neutral inline position. So we don't go against resistance. So if you find the head turned to the side and you're trying to get it back in neutral alignment and there's stiffness or pain, we don't try and move it against that. Immobilize the patient in his or her current position. Cervical collars. Provide preliminary partial support. And all they are doing is restricting motion of the cervical spine. Should be applied to every patient who has a possible spinal injury. To be effective, a rigid cervical collar must be the correct size. I cannot overemphasize that. So you cannot put on a cervical collar on a patient and it is not properly sized. That can cause further complications. So if you're not measuring the color, don't put it on. It needs to be the correct size. If it's correctly sized, it will not shift from its position. The cervical collar should rest on the shoulder girdle and provide firm support under both sides of the mandible without obstructing the airway or ventilation. Once the patient's head and neck have been manually stabilized, assess the pulse, motor function and sensation in all extremities, then assess the cervical spine area and the neck. These are things we will cover in skills. For a supine patient, secure to a long backboard or vacuum mattress. The vacuum mattress is more appropriate for a geriatric population. You need up to 4 persons to properly log roll a patient on a spine board. You may also slide the patient onto the backboard or vacuum mattress. Once a patient is on the board, if they are not properly positioned, at no point you push them across the board. You always move the patient down and up in a straight line to align them on the board. Vacuum mattress, an alternative to long backboard, is a vacuum mattress. It molds to specific contours of the patient's body. It is perfect for the geriatric population and persons with abnormal curvature of the spine. It can be used on a supine sitting or standing patient, so it's a very nice equipment to have on the unit. Sitting patients, use a short backboard to restrict movement of the cervical or thoracic spine, then secure the short board to a long board. Exceptions include situations in which you or the patient is in danger, you need immediate access to other patients, the patient's injuries justify urgent removal. So in other words, we will use a short backboard device if the patient is found in a sitting position inside a vehicle and is stable. If they are unstable, we do rapid extrication, which is quickly putting on a cervical collar and sliding a spine board underneath the patient and getting them out of the vehicle. Standing patients, immobilize the patient to a long board before proceeding with assessment. Establish manual inline stabilization and apply a cervical collar. So if you find a patient standing, we don't want them to walk over to the stretcher. So if you find a patient standing and he was the driver, and you look at the vehicle and the steering bent up, it's him bend it up. So if he's standing, you don't want him to move. We need to get him on a spine board from that position. So position the board upright directly behind the patient. Carefully lower the patient as a unit under the direction of EMT at the head. We don't necessarily have to do it this way. So I'll show you this way that the slide is giving points for, and I'll show you another way of doing it where it's a lot easier. Because I don't believe in putting the patient on the spine board on the ground and then picking up the spine board to put on the stretcher. There's another way to get the patient on the stretcher. Spinal immobilization devices assume the presence of spinal injury in all patients who have sustained a head injury. Use manual inline stabilization or a cervical collar and long back board. And a backboard is a full body splint. Short boards, this is your Kendrick extrication device. This is what we would use to take a patient out of a motor vehicle if they are stable. So they are stable, but they can't move. They have some injuries. We will use this device to take them out. It's not commonly used anymore because there are more viable options. But I'll still show you how to use the KED because it's a part of the national registry testing. So it's a vest type device and rigid short board. It's designed to immobilize and restrict movement of the head, neck, and torso. Used to immobilize non-critical patients found in a sitting position. Need at least 3 persons to use a KED. Spine board you're familiar with. So it provides full body spinal immobilization. So think of your spine board as a full body splint. That's what it is. Provides full body spinal immobilization and motion restriction to the head, neck, torso, pelvis, and extremities. Used to immobilize patients found in any position. Helmet removal. Now for your helmets, if the patient has on a helmet, what you need to determine is if their airway is compromised and if the helmet is tight enough, right? So if is there limited motion with that helmet on. Once the airway is compromised, the helmet has to be removed. If they are stable and the helmet is fitting tightly, then you leave it on. It can act as a head immobilizer. A helmet that fits well prevents the patient's head from moving and should be left on, provided that there are no impending airway or breathing problems. It does not interfere with the assessment and treatment of airway and ventilation problems. You can properly immobilize the spine. Remove a helmet if it is a full face helmet. It makes assessing or managing the airway problems difficult. It prevents you from properly immobilizing the spine. It allows excessive head movement. The patient is in cardiac arrest. There are various methods depending on the type of helmet, but most of these methods will require more than one person. So it can be 2, it can be 3 persons, can be 4, but various methods exist depending on the type of helmet. So removing a helmet should always be at least a 2-person job. You should first consult with medical control about your decision to remove the helmet. Alternative methods. The disadvantage is that it allows the helmet to be removed with the application of less force, therefore reducing the likelihood of motion occurring to the neck. The disadvantage is that it is slightly more time consuming. So as I said, you have different types of method for removing the helmet, and you can Google helmet removal for EMS or type it in on YouTube. So you'll see different types. And when you look at the different types, think about the disadvantages. Not going to go into the details of removing the helmet. That's something that we will cover in class if I'm able to locate the bike helmet. Right, we'll do it in class. Now, that's the end of your head and spine chapter. Very important chapter. As I said, this is going to be your most difficult emergency as it relates to trauma. So if you have a seriously injured patient who has complications with head and spine and ventilation complication, you have a difficult emergency. This type of call cannot be effectively dealt with 2 responders. You're going to make errors. So errors will occur, but there are some errors that we do not want to occur, especially if we have a critical patient. And the commandment in EMS, the EMS commandment is, thou shalt not do it what thou cannot take it back. So thou shalt not do it what thou cannot take it back. So anything you're going to do in the field, make sure you can fix it if something goes wrong. If you can't fix it, you shouldn't be doing it. All right, so that's head and spine. Let's look at the questions. Question 1, quickly. So let's run through these questions before 10. Go.